Good morning, Klaus. Chairman, colleagues, I am a speaker at this course, and I'm also a representative of the ESCA board, which we happily gave support to the society. David Dujour is our president, and Jacques, next president, Roland, and we are all together 13 people, including the section chairman. I present their greetings. I would like to talk about ESCA a little bit. Being a member, a full member, will give you a lot of opportunities, including educational and academic activities. So ESCA, ESSKA.org is our website. And
you have a chance to do it in the welcome after the session. So concentrate in your presentation.
thank you.
And you will do it
I misunderstood you.
Okay.
He asked me to talk about ESCA, so it's later. So I ask you to be a part of ESCA. Can we go on with the next talk? I apologize, Chairman. I misunderstood. So, this is more fun to talk. First-time dislocators, when they come, what should we do? When is the best time to operate? Should we start with a conservative treatment or surgical treatment? I come from Acıbadem University in Istanbul. These are my disclosures. Shoulder dislocation is the most frequent large joint dislocation. Main cause is traumatic. Traditionally, we reduce it, immobilize it in a safe position, and then we go on with physical therapy to recover shoulder range of motion and strength. Instance of recurrent instability is 14 to 100%. And it's it's too much, almost up to 100% in some studies, less than 20 years, like Alex just mentioned. And when you look into it, it's not that much talked age, but when you look into the literature, it's very clear that age is a very important factor. Above 50 years old, it's even very less. And with the non-operative treatment, is not benign. In a study by Hovelius with 25-year follow-up, the 72% redislocation in ages between 12 and 22, 56% between 23 and 29 years of age, and 27 in patients older than 30 years. And so the patients between 12 and 22 years, 38% required surgical stabilization. By the classical study by Kiviluoto, immobilization for 3 weeks is recommended for the conservative treatment. But now the period and position is controversial. The Hovelius, in another study, showed that with multiple arthropathy developed in patients in 25 years. There are more in patients with multiple dislocation compared to those with a single episode. So not only the quality of life, but degenerative arthritis develops with these patients. And this was shown by other studies as well. Irrespective of the choice of position and immobilization time, the conservative treatment has a higher rate of recurrence. The alternative is surgical stabilization. With early stabilization, we will provide lower risk of recurrence in the young athletic population, and progressive soft tissue and bony damage will be prevented, and quality of life will be promoted, will be better. And the factors that affect outcome after an initial episode is age, pathology that comes with the dislocation, and level of activity. Numerous studies about the age that I just took some of them here, and I gave them by their names and title. But why more in the young? Because the young ones, the adolescent and the young people, are uncontrollable, and they cannot have a good decision-making process. So they have unconstrained activities. They do not fear of the outcomes. And also there may be some histological differences. The profile of collagen in their capsule and other tissues may be different. Collagen type 3 with elastic properties in tendons and ligaments were shown in an earlier study. So labral lesion, as I pointed out with the arrow, is the typical injury pattern. Labrum, that is connected to the inferior glenohumeral ligament, is the most important passive stabilizer of the shoulder in the during abduction. It prevents humeral translation. The labrum creates a socket deepening effect, and the Bankard lesion, as you see here, this now is the posterior, but I transferred this, so this is what I want to show you. This is the anterior Bankard, the typical Bankard that we see. If conservatively treated, the labrum heals in a non-anatomic position. So not all dislocation pathologies are the same. In a study by Baker, the 6 shoulders didn't even have any labral lesion because they were capsular laxity. 11 shoulders had partial labral detachments. In the third group, there were capsular tears and labrum detachments. So we have to understand which is the one that we will go conservative and surgical. So on the left is a simple labrum injury, but on the right is a recurrent dislocated shoulder that we have a bony erosion, capsular laxity. There's even not even a labrum there, so it has gone into plastic deformation. We may have the Bankard lesion is pretty common, and then we may have a bony Bankard, and then these are the additional pathologies that we will see: Alpsa lesion, Hagel lesion, and Glad lesion. So with the Taylor and Arthurus study, they said that 97% have Bankard lesion and 89% have an Hill-Sachs lesion, which is on the humeral side. So the humeral, the bone stability is important, but they may be individually or both of them may be there. And the glenoid part, the glenoid provides the arc length in order for the humeral head to stay in. And with the added curvature and the labrum, the humeral head is forced to stay in the humerus, in the glenoid. And on the humeral side, there are various reports, the degree of dislocation, but it's also important. And this is a visual of why it is important. So the Hill-Sachs, as you externally rotate, will go on the front of the glenoid. And if there's a glenoid fracture, it will easily dislocate. So having a Hill-Sachs is important, but more important is whether it's engaged or non-engaged. And then with time, the bipolar bone loss is even more important, not necessarily on the individual part. And then we have to decide whether the joint is able to dislocate or not. So we have to take into both parts. And this is best described by on-track, off-track system. So basically, the width of the glenoid should be more than the distance the width of the defect that's present. I will not go into detail, but with this system, you will get a very practical description. And of course, with the advanced levels, then we know that we have to operate on this patient after the initial initial dislocation. So with the patient's activity is the other determinant that's effective on the outcome. So overhead athletes, heavy manual workers, younger patients, high impact athletes are more prone. We need a specific tool. The ISIS, Bolo's ISIS is very practical. It's not served for the decision on the initial dislocation, but it's very practical. The more degree you have, then the more likely you will redislocate. This would be something best if we could discover something to understand who will redislocate his or her shoulder. We need to predict recurrent instability. So predicted variables in this study was age, bony Bankart, immobilization status, dominance of affected shoulder, and fear of re-injury. These patients did not dislocate as much as those who do not fear. So the case for early surgical treatment is high recurrence, risk of osteoarthritis. We need to operate. And the cons are technically demanding, potential complications. After the first dislocation, sequentially with every episode, it gets worse and worse. First, the anterior hinges detach, then irreversible plastic deformation, and then after the third dislocation, point of no return comes. So these are various studies that are in favor of surgery, and there are risks to surgical stabilization that we have to be careful of, and delaying the surgery influence the outcome. The results of surgery is better once they are done earlier. So my recommendation and my conclusion as a physician, orthopedic surgeon, I will give with this example. 22 years old male, active basketball player, traumatic dominant shoulder dislocation, did not choose surgery at first. So this is his images. He has a Bankart lesion plus simple Hill-Sachs lesion, less than 10%. So it is on track. So the width of the glenoid, the red is bigger than the blue. So this will not, this is an on-track lesion. So 10 months later, he comes with second dislocation, and this is the situation. In addition to an original Hill-Sachs, he now has a cartilage lesion and the humeral defect, and which is we will measure for the whether it's on track, off track, is lengthened. So this is not good for a 22-year-old. We don't want to see that. And now with this round-shaped defect, it's off track. It has become off track. Well, thank you for listening, and we hope to see you in Milano in May and in April in the Turkish Shoulder Society Congress. Thank you.